injected dose multiplied by the body weight. Already discussed the indications. It has an excellent for staging and follow-up for malignant neck masses. It is an investigation of choice for malignant lesion of unknown primary, for distant metastasis and synchronous primary tumors. It monitors the tumor recurrences in the post-operative neck. It excludes the residual disease after CTRT. It has a disadvantages also, like high cost, low spatial resolution, giving false negative results, and physiological tracer uptake like in thyroid, salivary glands, and in any inflammatory tissue, which may gives a confusion and gives a false positive results. Then another imaging modality, single photon emission (CT), which uses gamma emitting radio tracers to create a 3D images, and it is used to detect sentinel lymph nodes, thyroid and parathyroid adenoma. Again, the contraindication is for pregnancy and hypersensitivity reaction, and the sensitivity ranges from 60 to 90% for various head and neck pathologies. Then angiography, digital subtraction angiography, main mechanism is involvement of injection of contrast agent into the blood vessels to visualize the vascular structures using the fluoroscopy. It is used to evaluate the vascular involvement in tumors, preoperative planning, and assessing carotid body tumors and arteriovenous malformations. Contraindication because of contrast that leads to allergy, renal impairment, and bleeding disorders. Sensitivity is high, more than 90%, and specificity more than 95%. Then OCT, optical coherence tomography, mechanism of action using the near infrared light waves to create a higher resolution cross-sectional images based on the tissue reflectivity, just like similar to ultrasound. Indication is mainly used for superficial mucosal assessment. Uh, Superficial mucosal assessment, such as in oral cavity, oropharynx, and larynx, and useful for early cancer detection and margins assessment. There is now no contraindication, mainly limited by the penetration depth and motion artifacts. Sensitivities and specificities are higher, like 80 to 90% sensitivity and up to 90% specificity. Then there is one article comparing the diagnostic accuracy of USG, CT, MRI, and PET CT by the Masaki Takamura. It's a retrospective study in which 16 patients were studied with oral squamous cell cancers between 2016 to 21, and the results showed that PET-CT has the highest sensitivity and the negative predictive value, but lowest specificity and accuracy. Whereas USG and CT have the higher spatial resolution than PET-CT, enabling more accurate detection of morphological changes and internal necrosis, leading to the high positive predictive value. Some limitations of the study was a very small sample size, diversities of the primary sites and stages, and because of time lag from the examination, criteria such as short diameter or morphology, which may influence the results. One-to-one correspondence in the comparisons with individual lymph nodes, they were not 100%. Because prevalence in population is unknown, so positive predictive and negative predictive value may be incorrect, and multiple lymph nodes from the same person may not be independent samples. Then this is a diagram, a table showing the site-specific preferred imaging modalities, like already shown for the various subsites, which is the preferred modality, and the one which is an alternative or the complementary, and what is the reason. Then there are some other image-aided procedures like USG guided FNAC, which we do for evaluating any thyroid, salivary gland, or lymph node lesions, and to differentiate benign from malignant nodules. CT guided biopsy, we do to evaluate any patient of deep-seated neck masses, any parapharyngeal or skull-based lesions, and to assess bone lesions. MRI guided biopsy, again to see for the biopsy of deep soft tissue masses, perineural lesions or skull-based tumors. Then PET-CT guided biopsy for any suspicious metabolically active lesion or occult primaries. Fluoroscopic guided aspiration be done for aspiration of deep neck abscess and any drainage of salivary gland cyst or fistula. Then SPECT guided sentinel lymph node biopsy, which is for use for in head and neck cancers to evaluate the lymph node spread or in oropharyngeal cancers. Angiography guided embolization for preoperative reduction of various vascular tumors to control the bleeding, for example, in carotid body tumors and in AV malformations. Endoscopic USG guided biopsy for any paraesophageal, hypopharyngeal, or skull base lesions. Then some discussion of scans that we're going to start. First, starting with the CT cuts. Like,
will you discuss as low as possible so that we can go to the main cases? Okay.
Yes, sir. Yes,
These
sir.
everyone can read on their own also. We just
Yes, sir.
take the main points so that we can go to the main cases.
Okay, sir. Okay, sir. So, as it's been shown, these are the sagittal cuts, these are the coronal cuts, and these are the axial cuts that we can study. Then this is the another axial cut of CT that shows the various structures like based on the infra notch and supra notch part. Like in the part that we can see the structures like medial pterygoid plate, temporalis muscle, the pterygoid plates, and then masseter muscles. And in another section, in another film, we are seeing the various muscles like zygomaticus minor, then buccinator, then masseter, medial pterygoid muscle. Then at the level of oral cavity, some deep spaces that we see over in the axial cuts, like sublingual space, submandibular space, masticator space, pharyngeal, parotid, and parapharyngeal space, in the carotid space. And at the level of oral cavity, the other structures that we see like genioglossus muscle, hyoglossus muscle, base of tongue, then masseter. Then at the level of hypopharynx, we can see the in the axial CT scan cuts consisting of hyoid bone with the pre-epiglottic space, the two parts of the vallecula. Then there is an epiglottis, and laterally we can see the pyriform sinus. At the level of larynx, we can see various infrahyoid spaces dividing into 5 parts. That is the visceral space, carotid space, retropharyngeal space, posterior cervical space, and the perivertebral space. Then this is the coronal CT with puff cheek appearance, basically showing the tongue, palate above. Laterally, the short arrow representing the vestibule and the long arrow representing the lower GBS. Then in another slide of CD axial cut, we see the buccomasseteric region, which is bounded by the buccinator muscle medially, shown by the plus sign. Then the zygomaticus major muscle by the arrowhead, masseter posteriorly. Main contents of the buccomasseteric region is buccal fat, angular branch of facial artery, facial vein, buccal artery, and some nerves and the terminal part of parotid duct and facial nodes. Then these are the MRI images, starting with the axial cut showing the arrow representing the genioglossus muscle. It is a fan-shaped muscle which is better seen in the sagittal cuts, with the long arrow representing intrinsic part, and then the paired genioglossus muscles. Then this is another T2 weighted MRI image, axial cut, which is showing the hyoglossus muscle laterally, and then in the coronal image we can see the another hyoglossus muscle, and then Here we can, in another slide, we can see in the coronal image the palatoglossus muscle, and in the last we can see the styloglossus muscle. Then this is another slide showing the coronal cut representing the mylohyoid muscle, geniohyoid, and below we can see it is the T1 weighted image showing the arrow representing the black dot, that is the lingual artery. Then this is another CT image, coronal CT image, that is showing how the disease is involving up to the high masticator space, and same over the bony window of the CT shows there is a widening of foramen ovale, showing how there is a high masticator space involvement. These are some of my references. Now we are going to see some cases, one or two, to be discussed with Madhukar sir.
Yes, you can
Sir,
start with
sir.
CT,
Okay, sir. Okay, sir.
whichever you have, and you.
Sir. So,
Yes. So before giving any clinical detail, I think
sir,
most of us will be interested to know how to approach a CT.
yes, sir.
So how do you approach, Rijul, when you get a case like this? You don't have any history. How would you like to approach? Which sequence or which plane would you be preferring to see?
Sir, I will be mainly presenting the axial cuts of CT.
Yes.
To see the any bony lesion, as well as some coronal cuts.
So mainly
axial cuts to see for any oral cavity.
Yes. So we are looking at a CT of head and neck, which means mostly our target area is oral cavity, maybe the neck spaces. So when you don't have any history, you either scroll from top to bottom,
Yes,
like from the skull base to neck, and try to look up if you can pick up anything. So it is very important that you ideally start with a history, like where is the lesion? Is it in the oral cavity? Is it in the neck spaces, or somewhere else? So unless you don't have a very specific point, like oral cavity or till then you will not be able to precisely pick up a smaller lesion. Larger lesions, you don't worry, anything will be picked up. So you can scroll for the benefit of others also from top to bottom. Okay, Vijul, you will start from the top to bottom, like from skull base towards the thorax. So this is a non-contrast CT. Importance of contrast you will see in the later sections. So Rizul is now scrolling from top to bottom. Okay, go ahead.
Top to bottom.
Keep scrolling and try to pick up any finding, Rizul. Or will you level it as normal scan?
Normal, sir. This is a normal scan, sir.
Okay.
Then here we can see the orbital part. Some orbital part is coming into the section. Then we can see the nasal cavity, and
okay, again, I'll not waste much of a time. So you can keep scrolling down. I'll just tell you. See, what we saw in the introduction part, very good images, and the planes were also very nicely seen. But is it really that good enough to be seen in this scan here? No. That is partly because it is a non-contrast CT and partly because it is a thick section. Okay, so you switch to the contrast CT now.
Yes, sir.
So this partly happens because of the various window settings. Now what is called a window on CT, which has a fixed width and level values, and based on which it is called a window. Window can be a
दही
soft
ले
tissue
आइए
window, window can be a bone
और
window,
वो
it
प्रिंट
can be
आउट
a
ले आइए,
lung
जेरॉक्स
window.
करवा दीजिए।
So all the different kinds of windows are there with
वो
a
जो अभी
fixed
नया
presets.
वाला
You can also manipulate it by your hand to adjust the windows as per your choice. So that becomes a customized
हाँ
window. Okay. So switch to the contrast sections.
ये
Sir.
क्लास चल रही थी, अभी रुक जाओ थोड़ा, क्लास
Like
खत्म
in
हो।
the lower one, here is the contrast.
Yes. Sir.
Yeah. Now what you can see is the soft tissue differentiation is slightly better because of the contrast.
दूध ले आइएगा
enhancement.
सुधा का काऊ
Go
मिल्क
down to the neck.
1 लीटर।
Sir.
Go down. Okay. Now you can wait here for a while.
सामने है
Now in the orbits
इधर।
also you can see the muscles also start to enhance a little more than other muscles. The sclera will also enhance, so you can make out
उल्टे नहीं सीधे
different
इधर जाना है।
attenuations now. The attenuation of the fluid can be seen in the sclera posteriorly,
मन
and some enhancement can be seen in the vitreous
सर अभी
chambers.
पढ़ा रहे हैं मेरे को।
Go down further. When you reach some sections in a routine soft tissue window, you will not be able to appreciate the entire bony margins. This is one thing is very important. Whenever you are looking at a bony pathology, you should always switch to a bone window sections. Now you can minimize this and show the bone window.
Sir.
Yes, sir. Now in the bone window, as you can appreciate, every cortex is well visualized. The margins are well appreciable to everyone. You can comment on the sinuses. You can comment on the wall of the orbits. Okay, and depending upon the anatomy, like the greater wing of the sphenoid is here, and other things are all very clear. So when you are looking at a bone pathology, you have to switch to a bone window. This is what is a bone window. Okay.
Yes.
This is one thing. When you are looking at a soft tissue structure, you remain in that soft tissue window. But whenever you have to comment on a bony involvement or a bony pathology, you have to come to this bone window. Okay.
Sir.
So these are the
Yes,
temporal bones. Okay. Now you can go down ahead. So the face and neck area, the temporal bone, the mandible, and the maxillas. These are all mainly bony structures, and they are mostly evaluated on a bone window sections. Okay.
Yes, sir.
You can go down further. The moment you come down below the mandible and all, it is mostly soft tissue structures. So you have to evaluate more of the soft tissues in soft tissue window. Okay.
Yes, sir.
This should be the approach you start to evaluate your images, because you have to pick anatomy. Everyone knows, but how and when and how to interpret and on which sequence to see is important. Now you can switch the window in this section only to this contrast. Yeah, with the contrast. This one. Okay, now whatever you have taught here is. Can you outline the basic anatomy visual here?
Yes, sir.
Go down in the neck. In the neck only.
In the neck, sir. Yes.
You're going up. Come down. Come down quickly. No problem. Okay, you can stop here. What structure is this? Can you tell?
Sir, this is a tongue, sir. First, that we can see there is first the mandible, sir. Mandible part we are seeing. Then we can see the tongue. Then posteriorly we can see the part of the oropharynx. Some part, and
so again,
posteriorly the vertebra.
Yeah.
Yes.
The second thing that you people need to understand is that there are certain important landmarks, like at suprahyoid is one, infrahyoid is another. Okay, so accordingly you can stay at one or two sections and you can start looking at the planes, like where is the carotid vessels, where are the salivary glands, which is the masticator space. So all those you can do sequentially in the axial scan itself. Okay.
Yes,
So what
sir.
is the need of a sagittal and a coronal section?
Sir, sagittal section is mainly used to see for any extensive disease like hyoid bone involvement or extrinsic muscles of tongue, whether it is mainly in MRI, sir. If we do the sagittal cuts, we saw whether there's the extrinsic muscles involvement or the extent of disease for any, like to see for hyoid bone involvement.
Yeah.
Then
Actually, most of the things you can cultivate from the axial scan itself, but when you are looking at overlaps, like suppose this artery is a longitudinal structure. Okay, it is not an axial structure. Whenever you want to look at a longitudinal structure, you usually prefer it in its long plane, which will be sagittal or a coronal. So it is not like we will get some answer out of sagittal or a coronal section, but whether actually you are looking at a pathology or whether it is merging with some normal structure, sometimes you need to have just to confirm, just like in X-rays, we need two views just to confirm. So just to confirm here also, you need at least two views, which one is axial obviously, and the second may be a sagittal or a coronal thing. Okay. So it is mostly to better demonstrate the pathology. Well, I am understanding this, but you may not be understanding. So sagittal, like a tumor is longitudinal, like a neurogenic tumor is there and it is longitudinally placed. It is not well appreciable on sagittal, axial. But when you switch to a sagittal or a coronal section, you can appreciate the length of the disease also. So this is one point. And mostly MR and all we rely on all the three planes. Okay, now I think basic CT anatomy I'm not discussing here. I'm just discussing with Rizul what are the points which are like people like you, the clinicians and all, they should start interpreting the CT and how and which sequence and which windows should be used. Okay.
Yes,
So other people also here, if they want, they can ask a question here also. We'll try to discuss that also. Okay, if there are none, then we can go ahead with the MRI, which will give us more insight into the imaging.
If time permits, sir, can we discuss spaces and then?
Yes, we are going to discuss that only.
Okay.
Now we have this one again scan here of neck. Okay, Rizul, you can. What sequence will you approach first? What sequence plane?
Sir, first we'll go with the coronal plane, sir.
No, never. Don't go with coronal. Why coronal?
Axial, sir. First axial cut. Yes, sir. First with the axial cuts.
Yes. So
Top
we
to
will
bottom.
stop at this section only. Stop here only. Now you can see this is the parotid. Okay. If I think everyone can see the cursor. If not, everyone can see the cursor. Are we? Is my pointer like moving to all of you?
No, sir.
No, sir.
No. I don't know how to do that, but because I'm not the primary speaker, then I might not be able to like use my pointer. Well, Rizul, you can help me with that.
Sir,
Use your mouse only. It's no problem. Everyone will be able to see you.
sir, I'm using the tab, sir. I haven't.
Okay. In tab, long press the screen. Long press the screen, and there will be a pop-up where
ऊपर पेन दिख रहा है ना, उसमें टिक करो.
पेन में but annotate or mask zone or drop in area.
Okay.
पैरोटिड में ले जाओ ना, सर बोल रहे हैं.
Okay, you annotate only. No problem. Take the annotate button. Take the annotate button. There you can use a cursor. I think there is this one edit button is there. So zoom out. Go to the just go back out of this window.
Sir.
Just go back where all the three. Now there is a editing tab above. I think just next to the share button.
Sir, this.
not report one. Yeah, this one. Can you use this? Yeah, the red one. That is.
Yes, sir. Yes, sir.
So okay, you only help me with okay. Now
Sir.
I'll just pick up important landmarks like parotid here. So you just put a red dot on the parotid, right and left.
Sir.
So, okay, this is the parotid. Okay, all
Yes,
of you can see now, and now Rijul, from here you start inwards. You will try to explain the anatomy that you just spoke of.
Sir.
Inwards, go inside, because outside parotid there is nothing. So your dot is on the superficial lobe of the parotid, right?
Yes, sir.
Now now move your cursor inside and you just speak whatever you can see. Yeah, it's okay, it's quite visible.
Sir, then we can, so parotid ke just above we can see there is a masseter muscle, sir.
Yeah, you use your pointer. ये इसमें नहीं आ रहा है.
नहीं सर, वो या तो उस पे सर सिलेक्ट करने पे और फिर
नहीं, use hair only ना, no problem. You can do show, हाँ ऐसे भी चल रहा है, we can see.
Okay sir, okay sir. Sir, this is the parotid, sir. First,
Okay.
the structure. Then above is the masseter.
Yeah. Yeah, this one. Good.
Yes, sir. Then here is the tongue showing the genioglossus muscle, sir.
Yes.
And here is the another. This is the oropharynx part. This is the base of tongue.
Okay. Now stop here. Now you can see that certain structures have different intensity, and certain structures have different intensity, though they are all soft tissue. So masseter, the genioglossus, all have a similar intensity because they are muscles. Okay. So how do we say that a lesion is like hyper intense or hypo intense? We compare it with muscles only. Now most of the muscles are in the posterior to the neck, which is these erector muscles. Okay. So the intensity of the muscle is our image के अंदर का ही वो हमारा baseline है. Okay. So we will compare the intensity of any lesion to the signal of the muscle. Is it clear?
Yes, sir.
So whenever you are telling anything is darker, appears darker, that means it is darker than the muscle. If you are telling if anything is brighter, then it is brighter than the muscle. Okay. Now can you pick up one structure which is darker than the muscle here?
This.
Oropharynx.
Yes, sir.
There are at least 3 structures that you can pick, but I'm telling you just pick one. Oropharynx is darker. Okay, good. Another?
Mandible. So mandible.
Nahin.
Not the entire mandible. There are specific
but some
areas.
part of.
Can you point? Which part?
Sockets of tooth.
Cortex. Yes, the cortex is dark, but not the medulla. Okay. Likewise, these impressions of the tooth, they are all dark, but not the bone. The other dark thing is, the last dark thing is the vessels. Can you see? Put a pointer on the vessel, Visual.
Sir.
Okay, suppose this is ICA or maybe CCA. So vessel, so there are 3 things at least which are darker than the muscle. One is air. So air is outside the skin also is air, that is dark. In the nasopharynx, oropharynx also it is dark. Cortex, not the entire bone. The cortex is dark, not the entire bone. The marrow is not dark. Okay. The cortex is dark, and again the vessels are dark. Okay. But the concept of being dark is, why is it dark? They lack protons. Okay. Are you getting my point, everyone?
Yes, sir.
So So whenever you start interpreting structures, soft tissue structures, so there was one
Vessels, sir, why vessels should be dark then if
vessels
it's
are dark because they have moving protons. तो once now जैसे तुम आई और तुम्हारा दोस्त आया, दोनों को हमने एक लड्डू दे दिया, दोनों चले गए रूम के बाहर, वो लड्डू तो लेके चले गए, अब टीचर आए वो लड्डू बोल के where is the laddu? No one is there to judge them who took the laddu. Likewise, once the proton is being hit here, they move away from this field. So every time the other time the teacher comes and inspects, you get a fresh moving proton here. That's why they lose a signal. So again, the take-home message here is, if vessels have a darker signal and that is called flow void. Okay?
okay.
उसको हम लोग काला पीला नहीं बोलते, उसको हम लोग बोलते हैं flow voids. Okay?
Okay.
So vessels which have flow voids, that means they have moving blood in it.
Thrombus
What?
will be then white, sir.
What?
Thrombus.
Thrombus will become white. This is the answer to your question also. So if it is a thrombosed vessel, then it will become white. Okay. Now move down. Now I'm not going to discuss much about this anatomy only. Now try you. It's now your turn to pick up a pathology. There is a pathology shining.
Sir,
Find it.
yes, sir. Sir, looks like pre-carotid lesion is involved. Some carotid mass is there, which is extended.
The carotid first. So before telling it it's a carotid mass, you have to identify the normal structures here.
Yes,
Then you have to come to. Then you need to come to a space. Okay. Then you have to. Then you should jump to the diagnosis. So identify certain normal landmarks here first.
Sir, this is the carotid space, sir. Carotid. And the lesion is seen, the outgrowth lesion is seen, sir, which is near to that carotid area. Maybe differentials like it can be the carotid body tumor.
No, I'm not asking you the differential. Just tell me, this is the carotid, okay?
Yes, sir.
This is the lesion, and what structure is lateral to the lesion?
Sternocleidomastoid, sir. SCM. This one, sir. This is the SCM.
Yes, that is also important.
Yes, sir.
So you have localized the lesion which is in or around the carotid space, okay?
Yes, sir.
Then you identify the lesion and then you start defining the morphology, and then we'll come to the signal. So what kind of morphology is this lesion? Is it irregular? It is well defined?
Sir, it is well defined, sir.
Yes, it looks well defined. So you can scroll for your friends also so that you can see the entire lesion from top to bottom. Just scroll. No, scroll up and down.
Okay, sir.
Just scroll a little. So he is scrolling up and down, and there are now we'll see what is happening inside the lesion. So the lesion has a relatively well-defined margin, and it is abutting the carotid artery. Okay, I think the black phlovoid is the carotid artery medially. Okay.
Yes.
So when you are looking in this axial section, the maximum you can get is a round-shaped structure. But when you look at the same lesion in the coronal, now go to the coronal or sagittal plane, yeah, coronal.
Yes, sir.
Yeah, scroll it. Now hold it. Okay. Now what happens to the lesion? It is more oblong, right?
Mm.
So what you were seeing in axial was a rounded lesion, but truly in nature it is an oblong lesion. So looking at coronal and sagittal will help you get a complete picture of the upper and lower margins of the lesion. The whole 3D anatomy will come into your mind. Okay. So this is one important thing why we look at coronal and sagittal also.
So, sir, dimension we calculate from here?
No, actually, what resist and other things follows is the maximum width, but they also tell you can give one maximum this also, craniocaudal also. So in whatever plane it is the maximum, whether it is in coronal, whether it is in sagittal, that will become the maximum length. So you have to give a length which is maximum. It may be in the coronal, it may be in the sagittal, it may be in the axial also. So people give all three lengths also. Okay. Now further characterizing the lesion, you can see the lesion is very what? It is hyper intense or hypo intense?
Hyper.
Hyper intense. So it is hyper intense, and the lesion has some. You go back on the axial sections. Now, this is hyper intense. Okay, this is brighter than the muscles, but is it very bright or just bright?
Very bright.
Very bright. So it is so bright that it is matching the intensity of the CSF in the CSF or any other fluid. That means that the lesion has some cystic or necrotic component. Okay. Now again, in between the cystic or necrotic component, there are multiple fine septations or strands that can be made out. So what you have come to a conclusion in looking at the basic MR is that it is a well-defined oblong lesion with some necrotic areas. Okay, is it right?
Yes, sir.
So now in this space, what can be your differential?
Sir, it can be the carotid body tumor.
Okay.
Or it can be the any neurogenic mass.
Yes. So these are the only differentials: carotid body, neurogenic, some nodes itself can be this large node. So if now you come to a radiological aspect, then I'll tell you why it is not carotid body, why it is not a node. Okay, there are many n number of other points also which may not be of too much of importance to you people, but there are n number of other things also that we can add to this report. Like for this particular case, necrosis is against carotid body tumor. Plus, you did not look at the carotid carotid bifurcation status. Nodes are usually not this bright. Alright. So there are multiple other signals also which we usually follow. Diffusion is also something that we add, and there are multiple small like neovascular channels in a carotid body tumor, which will again be seen as a multiple small phlovoids. So all those are not seen here. So how do you differentiate between carotid body tumor and this schwannoma or neurogenic tumor? One thing that you can look.
That will be solid, na sir? Nerve.
Everything is solid only.
Doppler, color Doppler से सर वैसे
Multiple phlovoids, sir.
Phlovoids तो मैंने बताया ना कि phlovoids are just like vessels only, but there are no phlovoids here. So there are other things. You have to first look at the carotid bifurcation status. Just look at the carotid bifurcation. Go up, scroll up. Can you show the carotid bifurcation?
ये divide हुआ ना.
Yes, sir.
Yes. So whenever you want to like following a long structure, whether be it a nerve or a vessel, you have to come from the normal part of it. So when you come from like below up, going up below from the normal to the abnormal zone, then you will be able to trace it completely. So you can see that the lesion is not extending into the notch; it is lateral and anterior to the carotid, and the carotid is just abutting but not encasing. So there are other criteria like what is encasement, what is abutment. Okay. Now apart from this, can you pick up any other finding? Just pick up any other finding. इसको स्क्रॉल करो ऊपर नीचे. You can scroll this. Another important thumb rule is whenever you are not sure what you are picking up and you want to pick up anything, which sequence will you look into? Will it be T1 or will it be T2? Or something?
One for anatomy, na sir.
What sequence will you look?
So T2.
Obviously T2, but what type of T2? T2 with fat or without fat?
Fat suppressed.
Yes. So ये इसको छोटा कर दो. I go back to all those. Now wait here. Okay, the first box is what?
Coronal cut.
ये कोई ऊपर नाम भी लिखा होता है.
T2 is coronal cut.
Sir. Okay.
Sir.
This is coronal, but you can see the fat is being suppressed here. Just below it is a coronal where the fat has not been suppressed. Okay. So what is the difference between the two? You can pick up any findings. See, the current scan also, you can see there is a small lesion in your this current window itself. Can you pick up that thing? Can you move the cursor around? अभी करंट में जो भी इमेज दिख रहा है इसमें there is a small lesion that can be easily picked up. Is it true?
Sir,
yeah, this one only. But is it easily picked up on the fat suppressed images? Yes. Just उसके ऊपर वाले में.
Yes.
See, ये जो इमेज है जहाँ पे अभी तुम्हारा डॉट है, this is easily picked up in this fat suppressed.
Yes, sir. Yes, sir.
But this lesion, though present in the lower section also, but because of the surrounding fat and all the brightness around, it is not well picked up. Okay. So T2, fat suppressed or stir, are both the things are same. They give you a higher contrast resolution. Okay, because the fat is suppressed. Most of the light is off, and whatever remains is a pathological. So T2 is called the pathological image. Okay, because we can pick up pathologies very easily. And T1 is called the anatomical section or the anatomical sequence, because in that you can identify the anatomy very well. Okay, so there is a lesion, another lesion here also. All right. So let's see whether this is part of the lesion or it's a different lesion. Is it part of that lesion? Or is it a separate lesion?
Separate lesions, sir.
Separate. Now can you?
Yes.
Now this is the importance of looking at the signal intensity also. Now this lesion, is it more brighter than the previous lesion, or same to same, or maybe something else?
More brighter than the previous lesion, sir.
Yes, that means it is even more necrotic or cystic, right? How do you confirm that? Then how do you confirm on MR itself? Either you go and aspirate, but can you confirm on MR also? Yes, you can. When you look at the T1 weighted images here, okay, you don't have, I think, do you have the T1 weighted? This one, below 5वां number वाला, 5th number, नीचे इसके बगल वाला, yeah, this one. उसको scroll करो. Okay. Just wait. In the larger lesion, as you can see, the signal is not very low. Okay. I'll not go much into this T1 chakkar. Okay, it will be tough for you people. You can leave the T1. Okay. So now you have two lesions. Okay. One in the left precarotid region and one just above the. This is the thyroid lamina probably. Just around the thyroid laminas, and this is more necrotic. So how do you explain both of them? Are they multifocal lesions or are they separate lesions? Will MR help in this, imaging help in this or not?
Yes, sir, it will help, sir. These are the two separate lesions.
Yeah, but it can be, if one is neurogenic tumor, then other can also be a neurogenic tumor.
Yes, sir.
Anyone else who can add to it? Chalo, anyhow, I'll just complete this case also. So, this is how you pick up a lesion and how you try to characterize it. Okay, now ये छोटा कर दो इसको resume.
Sir.
Now in the T1 also this is neurogenic tumor, no problem. But the other lesion is not a neurogenic tumor. It was a retention cyst because it has a signal of brighter signal on T1, which suggests that it has some proteinaceous content. Okay. So important for you is to pick up lesions, and if you can characterize it further, very good. If you cannot, then the radiologist will help. But even some radiologists might label it as 2 lesions, and again you have to do a FNSE. So this is how you characterize lesion. Do you have another case also?
No, sir. Only 2 cases.
Sir, basic anatomy, sir.
Sir, can you please tell us how to assess the degree of encasement, sir?
Yeah.
Like once we go for carotid or assessment, sir.
Okay. So suppose this is the only case and you want to assess the degree of assessment. Okay.
Yes, sir. Okay.
ये axial T2 जो पहले लगाए थे वो लगा लो.
Okay, sir.
Fourth one from the yeah, this one. Zoom it. Now bring the carotid one, carotid to the lesion. Down, go down. Go down further. Okay, this is T1. This is wrong one you have selected.
T1, sir. हाँ, sir.
ये इसका नीचे वाला. Select, double click करो.
Yes.
Now scroll down to the lesion and carotid. Now you can come scrolling from this also. You can see that the carotid. This is the ICA. This is the ECA. Okay. Go down. Start going down. Go down. Go down. Yeah. Now just wait here only. Yeah. This is good image. Okay. Rizul, you do one thing. You put a small dot. Okay. You might not be using it.
Over the lesion, sir?
Not over the lesion, over the CCA. It is next to the CCA here, carotid. Put a dot on the carotid, yeah. Zoom it here only, zoom it here only. Don't double click it, zoom it here only. Double click पे वो भाग जा रहा है तुम्हारा. ठीक है, it's okay. I think everyone is visible. I think it's visible to everyone.
Yes, sir. Yes, sir.
Now primary pathology, before you go on label it as encasement, you have to first identify what is the primary pathology. Does it look like a malignant one? No, it does not. It has a very well defined margin, and it is more or less abutting the carotid rather than infiltrating or encasing it. So your first initial assessment should start from whether you are looking at a benign looking pathology or a malignant looking pathology. Okay?
Yes, sir. Yes.
Second thing is, when you see a rounded structure like CCA, you can divide it into 4 quadrants just like a clock or a pizza into 4 parts. 90, 90, 90, 90. 90 degrees, 90 degrees, 90 degrees, and entire becomes a 360 degree. So the degree of abutment is what is called the mass coming in contact with the vessel. So degree of abutment in this is more than 90 degree, but less than 180 degree. Is it okay?
Right.
Yes.
Yes,
Okay.
sir.
So anything which is less than 90 degree is definitely away from the lesion. Now, when it is more than 90 and less than 180 degree, it becomes suspicious. But since the disease here is a benign lesion, so it will not go into any encasement, any abutment. But if the same thing will be happening with a mass which has irregular margins, okay. So even a lesion which is of extending close more than 90 degree or close to 180 will become suspicious. Okay.
Okay.
Now anything above 180 degree, okay, is more in favor of, more in favor of like encasement. And anything which is more than 270 is definite encasement. 270, 360, these are definite encasement. Yeah. Now there are many other like fallacies to this. Some say that you can see that there is a thin rim of fat around the vessel. Okay. So many a times you people must be having this some plastic kind of tubers which will like wrap the vessels, but it is truly not encasing. And the moment you open up, everything comes out, and the vessel there was a thin rim of fat which remains around the vessel. So sometimes if even if there is a 360-degree encasement, okay, but you can still make out that thin rim of fat, which is also called the rim sign kind of a sign. Then also you can tell the surgeon that okay, this disease is not looking a malignant disease, but since the 360, yeah, you can go ahead with the resection. That thing is a different issue, but mostly this encasement is.
Sir, in this thin rim is not visible.
Because you are looking at a T2 section, na. For that you have to go to a T1 section where only you can see the ये नहीं वो तो हम लोग तब बोलेंगे ना जब हम लोग encasement की बात करेंगे. In this there is no encasement. Yeah, T1 पे देखो that same thing will be seen differently. Yeah, this is T1. Go ahead. Now another thing is this is like एक section में encasement की बात हो गई. Okay. See, there is a thin rim of fat all around the vessel.
Yes, sir.
This white one जो थोड़ा सा दिख रहा है वो.
White one. That वो सिर्फ फैट ही नहीं होता है, उसका वॉल का भी कुछ पार्ट होता है. Now the second thing is degree of ये area of contact. Okay, suppose the lesion is not abutting the vessel for more than 90 or 180 degree, but it is extending for a longer length, जो कि craniocaudal पता चलेगा. Okay. Suppose a lesion is abutting the artery for more than 3 centimeters in any length. Okay, then it becomes very suspicious. So focal abutments are less than 3 centimeters and longer abutments are more than 3 centimeters. Anything which is abutting for over a segment of 3 centimeters becomes suspicious. Okay.
Yes.
Okay, sir.
This is how you look. Now prevertebral fascias again हम लोग को भी ये MR is superior to CT because of the presence of the fat. What you're looking at is the fat. Just look at the fat symmetrically. If fat is symmetrical on both the sides, okay. So we not only look on the pathological side, but also compare it with the other side.
Symmetrical, sir.
Yeah. Suppose you are looking at in this plane only.
Yes.
Now in this plane only, suppose you are not able to pick up a lesion. It is a very small lesion. Okay? So, but you can definitely appreciate that on the right side, the posterior cervical space has fat. There is sternocleidomastoid on the lateral side, and carotid vessels are seen anteriorly. But there is no other lesion. Okay. Now, if you jump to the left side, there will be a new lesion which is not seen on the left side or on the right side. So this is how you pick up the lesions also. You compare it with the other side, which is the normal side. Since this was a bigger lesion, it can be easily picked up. But if it is a smaller lesion, then you might need all these fundas to pick up. Okay?
So for a smaller region, should we go for T1 images so that anatomically we can differentiate better?
For any lesion to pick up, you have to start with the non-fat images. T2, non-fat side.
T2, sorry, T2.
Fat side, T2 fat side. T2 fat suppressed. Okay. Because you will be able to pick up lesions because any tumor will have more proton in it compared to other structures. So they will appear brighter. And the contrast resolution also increases on fat suppression. So this is how you pick up the lesions. First, so to conclude, maybe we can say to pick up the lesions, we should use a pathological image like T2 fat sac. Then you have to characterize the lesion, whether it has a morphology which is similar to a benign lesion or it has a morphology similar to a malignant lesion. I think all of you must know that benign lesions are well defined. They have a cleaner margin, they don't have much of edema around, and they have good flames. with other structures. On the contrary, the malignant margins or the malignant lesions will have irregular borders. They will try to avoid the planes, fats will be lost, and they will have poorer planes with the surrounding structures. Okay. After you have characterized, okay, I'm looking at a benign lesion or a malignant lesion, there may be some lesions which are of intermediate group. Okay. So you can come to a conclusion and you can make a differential based on that. Then you start to calculate whether it is operable, whether vessels, muscles, nerves, whatever important structures are there, whether all of them are preserved or not. And then you finally calculate distant other lesions. Like incidentally, we were able to pick up a lesion in this patient also, which was not related to the other lesion, but maybe this may be the cause of its symptom. So whatever you are picking up, whether it is the cause of its symptom, that is also important. So, but the patient must have come to you because of this thyroid cystic lesion also, and you people might have picked up a new lesion in the neck. So that the symptom and that thing is correlating is also very important.
Sir, one thing like fat intensity is equal in T1, T2, or there is some difference?
Fat is slightly brighter in T1 because it is the main sequence. The frequency, the T and all are shorter in T1. That's why it is called anatomical image. T1 is called the anatomical image. Okay. But more or less, for practical purposes, it is same.
Okay.
Okay, fat is same everywhere. Okay?
Okay, sir. Thank you.
I think it will be better we keep on discussing cases more rather than just discussing the theoretical part, because it will give you a practical idea. The images, okay? Okay, I think Vinay can add to a closing remark.
Yes, sir. So that was very insightful, and thanks. We have discussed most of the things which is basics, and I think we have to do in the next sessions about site-specific scans.
Yeah, I think the next
we will do something about like thyroid or scan specific for larynx, features of extranodal extension, all these things. So we will continue this session, sir, so that you will be well versed with reading the scans. We need your help and your guidance in all these sessions.
Yes, I think whosoever is the next one, whoever is dealing with MR imaging or CT, they should prepare some kind of videos trying to get the entire Okay, even the Zoom wants to go off, no?
No, sir.
Okay, good night then, everyone.
Yes, sir. Thanks a lot, sir. We will continue the session. We will let you know.
Okay, sir. Thank you.
Thank you, sir.